Let's get 2 minutes on the clock for our first case. Your time starts now. All right, time is up. Let's have a look at some answers. Now, CKD, chronic kidney disease, is one of those areas that the college really loves to kind of hone in on. So expect there to be questions about CKD in the actual exam. Now, again, this is similar to things like congestive cardiac failure or COPD, where we have very clear, very available guidelines that we should be familiar with. Remembering, this is a consultant level exam. They want you to show that consultant level knowledge. So, of course, the additional risk factors we might see would be things like diabetes, established cardiovascular disease, a family history of kidney failure or kidney disease. I think you could specify either one. I wouldn't be putting a slash, otherwise you fall into that risk of overcoding. Obesity, and if you wanted to really be specific, you could say BMI over 30. An active smoker or strong smoking history, Aboriginal or Torres Strait Islander origin, and a history of acute kidney injury. Each of those things are ripped directly from the guidelines and are definitely going to get you marks. Now, there is another one that is put into there, which is, of course, hypertension. But the question here, if we're going to be really picky, says what additional risk factors. And so if you were to specify hypertension in there, you would technically be correct in that it is a risk factor, but it is not an additional risk factor because they want you to focus in on what is relevant to this patient that's been presented to you. So we've got some answers in here of smoking, type 2 diabetes, Aboriginal background, chronic use of Celebrex. Ooh, now that's a good one. Yes, I actually think that would be something that would probably get in there, and I suspect they would probably lump that into a history of acute kidney injury, because really what we're talking about there is NSAID-induced kidney injury, and I think that would probably be placed into that there, so very good answer. All right. Of course, we've got more questions here. So let's get 2 minutes on the clock. Well, 2 minutes on the clock, and your time starts now. All right, time is up. Let's have a look at what those answers are. We've asked for 4, but there are so many more things that can muck up the EGFR reading. And this is something that is, again, ripped from the guidelines, but it's also really important to know because, let's be honest, how many times have we seen patients with EGFRs that we're looking at and thinking, oh, that's very unusual for them? These are the kinds of things we should be keeping in the back of our mind to say, is this perhaps a spurious result? Because it happens all the time. So, of course, and I'll point out as well, this is different from that last question, which was asking specific to this patient. Here, the actual wording of the question is what specific clinical situations might make an EGFR reading unreliable or misleading. So this has actually opened it up then and said, okay, answer everything you can possibly think of. And sometimes they'll do that with these kinds of slightly trickier questions that might need to show a little bit more breadth of knowledge to give you that little bit more flexibility and freedom in your answers. So some of the answers here would be an acute change in kidney function or an AKI. If it's an acute change, it may be an acute dehydration or medication event, in which case subsequent testing might reveal that EGFR has normalized. People on dialysis. You will never see more bizarre EGFR electrolyte readings than people who are on dialysis. Their bodies adapt to really bizarre physiology, and so always take that into consideration. Now, if they've had a recent consumption of a lot of cooked meat, that will also do it. It's that heavy protein load. So consider reassessment when the individual's fasted or specifically avoided a cooked meal within 4 hours of blood sampling. I wouldn't put that in the answer. That's just something for you guys to know. Again, other types of exceptional dietary intake, so a strict vegetarian diet, a very high protein diet, or people at gym junkies and are on creatinine supplements are going to have abnormal physiological values, which is going to throw off our calculations there. Likewise, and this is again one of the reasons why BMI is not fantastic, at the extremes of body size, we're going to see difficulties in interpreting these values. So that also has to be taken into consideration. Any condition of skeletal muscle like paraplegia or amputees, particularly bilateral amputees, will have very different circulating volumes. And so, again, we'll throw up our calculations. High muscle mass can certainly do it. Again, this kind of factors into some of our gym junkies, but muscles will behave differently. Pardon me. Children under the age of 18, and this is one of the reasons why often when you're ordering pathology and it comes back, that EGFR field will be blank and it'll say EGFR calculation not recommended in those under 18 years of age. Likewise, severe liver disease, protein changes within the body are going to dramatically impact our interpretation. EGFR values above 90, there's a little bit of so what? There'll be a lot of variability, and so again, that's why they'll often just specify above 90 on pathology reports. And of course, there's a heap of medications that will interact with creatinine excretion. And two of the classic examples here, and in particular one that you'll definitely see all the time will be fenofibrate, but also trimethoprim. So those patients that get recurrent UTIs that seem to be on trimethoprim more often than not, don't ask me how they get it, I don't know. They just seem to have it in the water. That's going to impact their creatinine clearance, and so take that into consideration when trying to interpret their EGFR. Try and catch them in a period where they're off antibiotics to get a true baseline. Pregnancy, very well known. And as well, there could just be normal physiological variation in EGFR or laboratory variability, and they'll probably lump those two together into one group. The machines get calibrated all the time, but there is going to be day-to-day variability, machine-to-machine variability, lab-to-lab variability, and that also needs to be taken into consideration. If a patient suddenly goes to a different lab, uses a different machine, they might get a different result. Should be in that same ballpark, but do expect that little bit of variability to be there. Whew, lots of answers there. Lots of opportunities to get points. Of course, we've got another question on this here, so let's get 2 minutes on the clock, and your time starts now. All right, time is up, and let's have a look at some answers. Now, pardon me. This is one of those situations that, as they say, time wounds all heals. Unfortunately, despite our best efforts, sometimes patients do continue to decline and deteriorate, in this case, over the period of years. But patients do have more options now than ever before in terms of getting additional healthcare to prolong their life and hopefully quality of life. So, what specific risks should you discuss with Mavis regarding peritoneal dialysis compared to hemodialysis? Um, Lots of different things, but you could broadly lump them into some of these categories here. Increased risk of acute bacterial peritonitis. And on average, for patients that are on peritoneal dialysis, we can expect this to occur about once every 2 years. Obviously, good hygiene around the way they change their fluid makes a massive, massive difference. There are two main ways in which they can actually get peritoneal dialysis, and the way they change that can affect there. There is a risk of hernia as well. The massive changes in fluid volume within the abdomen weaken the abdominal musculature and does make them more prone to things like hernias, and as well increased risk of weight gain. The fluid actually used to dialyze is quite concentrated in sugar, and so with that, some of that does get absorbed into the system, and they do often have difficulties with weight gain, particularly if they're diabetic to begin with. It can be a bit exacerbated by that. So we do have some additional answers from the chat here, one of which I wanted to highlight here, periprocedural bowel perforation. So it wasn't one that I'd put into here because there are, this is kind of going into the immediate risk in terms of inserting ports and things like that. But yeah, it's definitely a valid answer, and I suspect in this instance enough people probably would answer that as well, and I think you would probably get 1 mark. Really, I think the big one to acknowledge here is the bacterial peritonitis, as you've already specified, so I think you'd be doing very well for this question. And coming in from Jenna as well, good household hygiene. Again, fantastic. That would probably be lumped into the risk of acute bacterial peritonitis in terms of that infection risk, preferably no cats. Yes, very true. So with this one, I would probably just say try and diversify the answers a little bit, because really the risk there is kind of talking about the same thing, if that makes sense. But definitely very good answers.